Hi, everybody. Welcome to this week's masterclass, Menopause, Hormones, and Feeling Like Yourself Again. I'm Lisa Hurley. I'm a nurse practitioner, and I love to talk about this topic. I think it's so important. Disclaimer, I'm a member of the North American Menopause Society. I am a certified menopause provider, and I'm also a menopausal woman. I always like to go over some terminology, because we need to be a little more specific when we're talking about some of these things, I feel. We'll start with perimenopause. What's interesting about perimenopause is there's no consensus for when it starts, how long it can last. The literature I've reviewed could be anywhere from 4 to 15 years. I've had plenty of women in their 30s who come to me and say, "Hey, I know this is early, but I'm starting to have these symptoms." We really don't know. You may be in that group, you may not, but just be aware there's no consensus. Menopause itself, very interesting, is actually the cessation or stop of your menses for 12 months. So that means 12 months, no period, you're in menopause for one day. The next day, you're postmenopausal. So we get that terminology confused all the time. Early menopause. Now that can occur, it's defined as occurring before the age of 45 for multiple reasons. Late menopause, after the age of 54. Induced menopause is basically the loss of ovarian function, usually due to surgical means, or sometimes we just don't know. It just happens. So once again, postmenopause, after 12 months and one day, no menstrual bleeding, you're postmenopausal, and that's who you are. The median age in the US for women for menopause, to go through menopause, is 52.5 years, which means basically 50% of the women it happens before, approximately 50% of the women it happens afterwards. So sometime around there. I also want to stress that this is a natural process. You're not broken. This is something that occurs, is going to occur either to yourself, someone that you love, someone that you know, sister, mother. It's going to happen. Unfortunately, it's untreated in the United States, multiple reasons. Women's Health Initiative study that was done in 2002, there was so much misinformation and set us back. It still sets us back. We still have a lot of providers that are resistant to treatment because of the way the data was interpreted back then. And of course, lack of study of women in general, that still today, we still need many more studies to really understand menopause and how to treat it. Lack of education for providers and for the population itself. Now, what I'm seeing is that population is much more educated. I'm seeing a lot more women who are coming in and advocating for themselves, which is fantastic. But I'm still hearing about their stories that, they saw their OBGYN or their primary and they're just told, "Nope, you're too young. Doesn't matter if you're symptomatic, you're just too young to start treatment." Or telling them that they wouldn't prescribe it, because they still have some beliefs from the misinformation from the WHI study. And of course, stigma. I know, especially for like my generation, we didn't talk about it. And I still run into women who are really reluctant to share some of the things they're going to because it's very private. And that's part of it. It's also difficult to navigate. How do you find a provider? If you've hit roadblocks, if you've done the things you think you should, you've seen your OBGYN, you've seen your primary, and you're being told no, then what do you do? And it's sometimes not covered by insurance, depending on what type of treatment that we're doing. So that can be frustrating. Symptoms, they're all over the place. And I think this is one of the things that um, we don't talk enough about because it could simply be that you don't feel like yourself. You're just not as interested in the things that you used to be. Could have bloating, palpitations, anxiety, weight gain. Typically I hear about especially in the abdomen, definitely changes in your skin, itching in your ears, ringing in your ears. Of course, irregular periods. Everybody associates that with perimenopause, and that is true. You could have shorter cycles, heavier cycles. It could be the spotting, or just skip a couple of months and then start again. Fatigue, brain fog is a big one, dry eyes, joint pain, of course, mood swings. But vaginal dryness, we don't talk about that. All of a sudden, sex is uncomfortable, or you notice that you're starting to have urinary tract infections, or you're having some vaginal odor. Hot flashes are the one of the hallmark, and interrupted sleep. How do you assess this? Honestly, we do need baseline labs. That is true. But we don't necessarily treat off what your lab values are. And I don't think most people should, because that fluctuates wildly depending on where you're at in your cycle and your life. Um, it really is more about your symptoms, what's happening to you. You can have a normal FSH, for example, until late into perimenopause, or actually into menopause, before you actually have labs that say, yep, here you are. You're already, the horse is out the gate already at that point. Uh, Really, and it's treating symptoms, low libido, brain fog, poor sleep. For me, with my patients, we have to discuss what your goals are. What would improve your life the most? Which one of these, or which combination of symptoms is really causing your problem? So it's very individualized. Something that would bother one woman, say low libido, another woman doesn't care about that. They don't necessarily want that treated. There's multiple types of estrogen. Um, I won't bore you with them, but just know that depending on where you're at in your life cycle, different strengths. Typically, estradiol is the what is in not only birth control but in HRT. Although there's some that combine the E2 and the E3. There's multiple ways to obtain it and utilize it. Of course, oral. Think birth control pills, vaginal, which every woman, as you're going through, especially by the time you're into menopause, you're having vaginal dryness, you should be doing vaginal estrogen as well. But you can treat with creams, you can do transdermal patches, you can do injections, you can do pellets. These are all very individualized, metabolized differently. And it really, once again, it's about your lifestyle, what we're trying to treat, and what your overall health is. If you have any other health issues that we need to be cautious, one type of delivery system versus another. For example, oral estrogen, um, it can increase your risk for blood clots. Transdermal is metabolized differently, and so doesn't have the same risk profile. Progesterone, synthetic, that's really the study I talked about, WHI, that was based on synthetic hormones, um, and then natural bioidentical. Testosterone as well. That's something that we need to talk about in men and women. So we all produce all three: testosterone, progesterone, and estrogen. And for both men and women, testosterone starts to drop slowly, sometime after 30, just kind of a ballpark. It is a really good energy, mood stabilization medication, and can help with sleep, does help with libido, your ability to maintain muscle mass and prevent osteopenia, osteoporosis, thinning of the bones. Unfortunately, it's got a little more side effects that are undesirable. Acne, hair growth or loss, mood swings. Most of these are dose dependent though. It can increase your hemoglobin and hematocrit. So when you're on testosterone replacement, it requires a little increased monitoring. You will need additional lab work, because if those things start to elevate, it could put you at a higher risk for a blood clot. It can cause voice deepening in men and women, as well as clitoral enlargement, and this could be permanent or not. And in men, also testicular shrinkage. So these are all things we have to talk about. Once again, you can get it testosterone creams and gels. And for most women, we want to start with creams. The reality is there are no commercially available women's dose testosterone. So compounding pharmacies can get us a more accurate dosing. So typically that's where we go. You can also do oral or injections or pellets. All of these have different risk profiles and they're not for everyone. So very individualized. Once again, we have to discuss what our goals are, risk versus benefit, and then we choose, a treatment option that would fit your life the best. And then we can change it if something changes in your life or you don't like a particular style for whatever reason, we can change delivery. Now, skin, that's a big one. We have so many changes in our skin as we go through perimenopause, through the menopause transition, especially thinning, loss of elasticity, loss of collagen. What can you do? Definitely need to stay hydrated. Definitely collagen supplementation. There's topical products such as we have a really good compounded estrogen that has copper peptide, hyaluronic acid. Once again, that can work wonders, helps with fine lines, wrinkles. But the mainstay is medical grade skincare, facials, lasers. If you are having issues, as we all do, gravity wins, you can do a combination of fillers, neurotoxin, and of course, the collagen stimulators are very helpful during this period of your life. We have different topical copper peptide with hyaluronic acid, plush skin pads. Those are available here at Fulcrum, either in the store or online. Now, one of my take homes is I think we don't realize that all types of hormone therapy postmenopausal appear to confer some type of benefit, unless you're an unlucky person and it's contraindicated for you. But there was a million woman study that really, it didn't matter what type of hormone replacement you were on, didn't matter if it was synthetic, bioidentical, didn't matter if it was transdermal, it all really did confer a significant protection against osteoporosis, osteopenia. So that's, as we get older, that's something we need to be very aware of. Adverse effects, I touched upon some of them, but when we are introducing hormone replacement therapy in women, you can have uterine bleeding, abnormal uterine bleeding, breast tenderness, nausea, bloating, fluid retention, changes in the shape of your cornea, headaches, dizziness, mood changes. You can have gallstones, you can have hair loss, you can have increased facial hair. There are many others. Those are just a few. So, who should not take hormone replacement therapy? First of all, if you know you have an estrogen sensitive breast cancer, if you know you have any active cancer, you should not take it during that time. Unless we are talking to your oncologist and there's some appropriately selected patients that it would still be appropriate for, but that's a case by case. Migraines with aura. For those women, they probably should not start hormone replacement therapy. Any undiagnosed abnormal bleeding, that needs to be investigated before we start any type of therapy. We always talk about the DVT or blood clots because with estrogen and testosterone therapy, it can increase your risk. So once again, it's not 100% contraindication. It really depends on what caused them. And there's different delivery systems that can decrease your risks, but pretty much it would be a no unless we talk about it and your individual case, the risk uh, versus benefit ratio would be appropriate. But any type of liver dysfunction and, of course, pregnancy. Any type of hypersensitivity to estrogen therapy, transdermal therapy, and one of the little peanut allergy should not use retail progesterone. We would have to get it through a compounding pharmacy. Take home points. If you have a uterus and you're on estrogen, you also have to be on progesterone. If you have a clotting disorder, oral estrogen, we should avoid at all costs. We may be able to do topical, vaginal. You should still be able to use vaginal, and we may be able to do transdermal, but we would have to look at your case individually, talk to a hematologist that you're seeing. If you're using any form of testosterone, we do have to follow up labs, as I explained. And birth control is typically a lot stronger than hormone replacement. So I don't know why we're so afraid of hormone replacement therapy. I really think that for most women, the benefits outweigh the risks. And, at the end of the day, everything has risks. We have to evaluate what the risks are for you, what we're trying to treat, make an informed decision, and move forward. But you need to feel like yourself. When we're going through this in our life, we need some help. And I think you shouldn't be afraid to ask for it. Are you ready to feel like yourself again? Um, for me, when you're seeing me, this is one of the fulcrum differences. Of course, I'm menopause certified. We'd come in, we would do lab draw and then a follow-up lab interpretation. If your insurance covers your prescription, absolutely. Typically, insurance will cover estrogen and progesterone for women. They don't cover testosterone. I've not found that once. We do use FDA-approved compounding access. Traditional pharmacies, if we can't get it through them, we've got a lot of options. We also utilize pure encapsulation for pharmaceutical grade supplements and thistle food product programs. If you have any questions, I'm here for you. You can take advantage of our 3-year anniversary special. We really have a really fabulous uh, program right now. It would include not only the consultation, very comprehensive, personalized hormone wellness assessment, customized treatment plan, and 3 MSALA sessions. So I didn't really touch much on MSALA. MSALA is an incredible device as women, and this is men too, get older, you can have issues with urge or stress incontinence. This is a device that can help strengthen the pelvic floor. So this would be 3 sessions included with the consultation through the end of July for $450. So that's a really incredible savings. So I would also like to mention that next week we're going to be talking to Dr. Hill, everything about facelift. Right now, I'd like to open it up for any questions we might have. I did really good on time. At 62, do you qualify for HRT? It's a really good question. We used to be told that you could only be on it for a certain amount of time. That's not true any longer. If you don't have any contraindication, HRT until there's some reason we should stop it. We totally have changed the way that we think about this. What are your thoughts about cervical family history and HRT? I'm not quite sure what you mean about that. Are you talking about a cancer or are you talking about vaginal estrogen and how it supports the tissue? Oh, cervical cancer. Okay. Now, if you've had a complete hysterectomy and you are cancer-free, that would not be a contraindication. I see that. Yeah, it would not be. Um, but if you have active cancer, no, we wouldn't start it. You'd have to go through the process and for full treatment before we would introduce it. Yeah, yeah. For especially if it's just family history and you've not had it yourself, absolutely. There'd be no contraindication. It's funny, they're doing testing right now on men with estrogen therapy for prostate cancer. It's kind of crazy. Oh, you're very welcome. Okay. Unless anyone has any other questions, I think we're good here. Thank you guys for spending the time, and you have a great day.